Hello, this is Dr. Gada. Today I'm going to speak with you about history taking of a case of headache, patient complaining of headache in a NAC OSCE setting. First of all, as we know that NAC OSCE cases usually can be history taking or physical examination or a combination of both. Most of the time, headache would be history taking, and you have 8 minutes to do miracles. That's what we are going to do through this time. And let me tell you that what truly excites me about medicine is how it is an art and science coming together in a perfect harmony. A skill that is required of processing information, communicating effectively, and striking the balance between empathy, firmness, practicality, and compassion. And this is something that you'll have to be aware of during your station when you're taking the history or doing the examination. You have to do very practical, do what you have to do, and show empathy all throughout your station. And let's not forget that the complex abilities of taking and analyzing histories constitutes the apex of this art form. Taking patients' history and doing an examination is like playing detective, right? As you know, it's worth noting that the renowned investigator Sherlock Holmes was conceived by the late Sir Arthur Conan Doyle, who actually is a physician like us. Imagine playing the role of a real life medical detective. And let's do this practice not only for the exam, but to be better physicians. Believe me, the satisfaction that comes from going home after a long day in the hospital is being able to use your knowledge to see things that others miss, draw inferences, and make decisions that could save lives. So our profession is amazing if we really put into perspective the holistic elements of communicating and understanding the patient and finding solutions and executing on this on our decisions. Okay, so for let's go back to headache. Now, outside you have 2 minutes to read the notes on the door. So read it carefully, write the name, write the age, the gender, female or male, and the setting, whether it is an office or ER, because how you will run the questions will be different. The main complaints, and just jot down based on what task they want. Do they want you to do history or examination, or history and examination, or just counseling? And always be ready with differential diagnosis, at least 4 to 5, even though if the diagnosis is obvious, and outline what are the main differential diagnoses, especially life-threatening diagnosis that you have to exclude very early. Also, remind yourself that you have to show empathy between the questions as a response to the patient's answers. And now I will share with you exactly what outline to use. Okay, first of all, let's write the differential diagnosis on the note. Once you see a patient presenting with a headache, this is the differential diagnosis that you'll have to write. Okay. First, exclude life-threatening conditions. Right? Headache means I have to exclude increased intracranial pressure, subarachnoid hemorrhage, infection like meningitis mainly, but also encephalitis. Put it in perspective. This is in patients coming to an emergency, especially vasculitis like temporal arteritis, and focal neurological deficit, if it's mentioned, like space occupying lesion, brain cancer, brain tumor, stroke, and of course, 90% of the patient coming with headache actually have primary headache, which unknown reason or unknown cause. So we have to write. You have to exclude migraine, tension headache, and cluster headache. So let's start. First of all, now you have these 2 minutes. You've written your differential diagnosis. The next step is knock the door. Um, Hand your sticker to the examiner. Sanitize, sorry for the spelling mistake, but you know what I mean. Sanitize and introduce yourself. How you do introduce yourself? For example, hi, good morning, Mr. or Mrs. This is the patient's name. And if you want to, you're not sure how to pronounce it, you just ask them, would you tell me how to say your name properly? This is also reflects that you are under reflects respect, a form of respect. I am Dr. So and so. I am the physician on duty, and I understand you are here because of. And you write, of course, you will mention the whatever mentioned on the paper outside. In the next few minutes, I'll be asking you more about it to figure out a working plan. Is that okay? Okay. Now, next step is the history of present illness. So this is acronyms I use, and you can use your own, but always use the same acronyms for all cases. So I'm sharing what I've used. I used OCD, PQRST, and AEER. Let's see what do I mean by that. First of all, the OCD. OCD is onset. Is it sudden or gradual? The setting, what you were doing when the pain started. The course, was it continuous or coming and going? Is it worsening or improving since the moment it started? Is this the first time, or is this repeated? It means recurrent. And the duration, how long is the pain? How long is the headache? And since when did it start? Okay. Second, PQRST, and this is for any form of pain, and headache is a pain. So the position, is it in one side or is it in both sides? Is it in the headache, or the occipital means the back of the head? Is it above the eyes? Do you feel it in the face, in the jaws? Also, the quality, is it pressure? Do you feel pressure on your head, or do you feel pounding or throbbing? Is it sharp pain? Is it dull? Is it the worst headache ever? And of course, when we have to ask this question because we won't exclude subarachnoid hemorrhage, for example. Radiation also. So R for radiation. Is it going to your neck? To your neck? Is it going to your eye? To your jaw? And then severity in a scale from 1 to 10. 1 is very minimal, and 10 is the worst. How do you describe your pain? Okay. Then timing. Is it worse in the morning? For example, like any cause of increasing cranial pressure, mostly cancer or tumor in the brain, or is it the worse in the night? Then they will think more about tension headache. Then PAAR, which is P is provoking factors. Did you have a trauma? Was a head position, change your head position that started the pain? Did the pain start in sleep? Is it the physical activity that you've done? Chewing? Is it lights or sounds? And again, aggravating factors. What makes it worse? For example, again, your head position during sleep, physical activity, chewing, light, sound, and eye strain. So by sleep, I mean also lying supine, because as we know, if there's increased intracranial pressure, the headache is worse when lying supine or sleeping. Okay. Physical activity also aggravates the subarachnoid hemorrhage and any form of increased intracranial pressure. Okay, so chewing is for temporal arthritis, and so on. We'll discuss that also later. What about alleviating factors? Did you use any medication? Was sleep relieved your? Did sleep relieve your headache? If you switch off the lights, does it relieve your headache? Did you take any treatment from any doctor before? And then we have risk factors. This risk factors will be reviewed when we go to the next step. Okay. Now, here comes the importance of having a list of differential diagnosis and excluding the life threatening conditions first, or vision threatening conditions as temporal arthritis. So, for example, Do you have blurred vision? Do you have any pain while chewing? Any cord-like structure in your temple? Any joint pain? Because polymyalgia rheumatica, any fever, any chills. Again, for space occupying lesion, is the pain, if it is the headache constant? Is it worse in the morning, as we asked before? Is the area neurological deficit? Do you feel weakness anywhere? Is the pain aggravated or increased by coughing or sneezing? And for meningitis, fever, chills, rash, stiff neck, and nausea and vomiting. Subarachnoid hemorrhage, you'll ask, is it the worst ever headache? Does it feel like thunderclap? Is there a nausea and vomiting and stiff neck as well? Stroke. Um, you'll ask about limb weakness, about vision loss, clumsiness, numbness, and so on. And even though if it is the diagnosis is clear, and you have to ask about the other differential diagnosis. Okay. And here also we should forget, don't if even we our aim is to help the patient, so we have to also diagnose their headache even if it is not life threatening. So I will ask about migraine. Is there any aura like seeing? And 90% of the aura in migraine is visual, so we have to ask about seeing flashes, or zigzags, or spots. That makes you know when is the headache coming. Is the relation between the headache and your menstrual period for a female? Is there nausea and vomiting? Photophobia? Does the light worsen the pain? Does the some sounds worsen the pain? Or even smells? Osmophobia means some smells will worsen or trigger the pain. And scintillating scotoma, which is blind spots, also, which all of these are all reversible. Sometimes also, very rarely, it can happen in the form of vertigo or weakness on one side of the body. Now, tension headaches is usually, there's not much associated symptoms. It's usually related to stress at work or at home, and usually it's at the end of the day. Cluster headaches are very important. Usually they are, there will be, you'll ask about red watery eyes, a runny nose, sweating during the headache, swelling of the eyelid, or dropping, because they can have ptosis, dropping of the eyelid. The risk factors, as I mentioned, we will review it when we go through the past history. So you can write the risk factors, or you can put it under the past history, which is hypertension, any immune compromising situation like HIV. So we think about infections, cancer, recent trauma, any form of seizure, history of glaucoma, polymyalgia rheumatica, and other rheumatological diseases like causing vasculitis. And don't forget, if she's a young female, to ask about LMP, which is last menstrual period. Surgical also, recent LP, any previous cancer, any intracranial surgery. Always ask about allergies, even if you think it's not irrelevant for headache. It is important, whether environmental or medical. Don't forget to ask about medications. That's why PAM, blood thinners, steroids, or contraceptive pills, using nitroglycerin, excessive use of analgesics, and excessive also caffeine use. Both can cause headaches. What about a hug? Hug means hospital. So in case that you forget to mention, to ask about the surgical past history, you can ask it when you remember. Oh, were you admitted recently to the hospital? Any procedure were done to you, and so on. Don't forget about asking the basics, but systemic review, which will be we will not forget the systemic review. We'll add it to the associating factor, which is we are just tailoring our questions to our differential diagnosis. For GIT, we can ask about constipation, because it's one of the most common causes of tension headache, for example. Then family history. FOS is family history, occupation, social, and sexual. Now, family history is important to ask about migraine, brain cancer or tumors, subarachnoid hemorrhage, strokes, seizures, and any form of aneurysms. Occupation is important to ask, even if you feel it's irrelevant, but must not forget about asking. Social history is important. Illicit drug use, again, sorry for the mistake, spelling mistake. Smoking, alcohol use, any stress at home or at work, and recent travel, again for infections. Sexual history, we just ask about basic, are in a sexual relationship. And then if you feel that you need to ask, especially if there's illicit drug use, it's better to ask in detail about the sexual history. So basically, you will ask whether they are sexually active, if they are in a relationship, if they are in multiple relationships, because again, infections and meningitis, encephalitis, any are they practicing safe sex, and what is their orientation and preferences. Now, always you have to transition, moving from one section to the other, in order to show empathy. So when you start asking about social history and sexual history, it's nice to say, Mr. or Mrs., I'll ask you a few questions which may sound personal, but these are part of the routine questions in my medical history. Is that okay? Um, don't forget, transitioning between section to section is very important. For example, in the very beginning, when you are asking about the pain, they say, "Oh, God, I'm in severe pain. Oh, I'm so sorry for that. Bear with me, please, for a few minutes. We will be able to sort this out. I'll give you something for the pain once we finish." Okay, so always be alert to whatever um, clues that the patient is showing you, that you have to react to their questions, not just going following a routine and that's it. Okay. Okay, so I just needed to mention that you have to show empathy all through. Okay, next. So now we finished, we took the history. You will say, "Thank you, Mr. or Mrs., for answering my questions and or providing the information in spite of your pain. If you have any questions, please feel free to ask. I believe you may have." You can say that, or you may not. It's not very important. What's more important, you say, "I'll do some physical examination and run some tests to confirm the diagnosis. Do you have any more questions?" And that's it. Now, this is wrapping up. And let me tell you something. Now, the marking in NAC depends 40% on your medical knowledge, which is history taking, the questions that you'll ask, your differential diagnosis, you wrap up the plan that you will tell your examiners about, and the questions based, of course, on the history. Now, the communication skills, 60%, as far as I know, the marking will be on communication skills. That's why introduction is very important. Rapport is very important. Eye contact, listening to the patient, facilitating, good to know. In between, you'll ask them, "Oh, good." When they say, for example, "I stopped smoking." "Oh, that's amazing. Good to know. Well done." Okay, for stopping smoking and things like that. You've done well by doing so and so. Be kind and always, control the pace. Be careful to control the pace, not allow them to interrupt and start speaking about other things. You can say, if they start asking things not or speak about unrelated things, you can interrupt. Your well-being is the most important thing. So let's go back and figure out what's going on. Okay. Always be non-judgmental and address their concerns. Don't So be human. And believe me, in the beginning, I thought it's impossible for me to do all of this in 8 minutes, but it is very possible with practice. I will show you one thing that I used to summarize everything, and I use that for all stations. For example, for headache, and the way I practiced, I practiced remembering this, and this is called mind map. And in mind map, the good thing about it that after some time your brain will absorb it and will see everything in one page in a branching manner similar to the nerve cells. So you can use that. Always use one style, whatever you're comfortable with, and follow through. And good luck. Thank you very much for listening.